All right. Well, welcome everyone. Over the past few months, we've really been working on updating our transplant protocols, and we have great minds involved in coming up with these transplant protocols for our center. Dr. Montero, Dr. Cancio, Dr. Mayer, and I would like just to present a small portion of what we've been working on, and that's screening and prophylaxis part. It continues to be work in progress, but we looked at all the recent evidence and such, and so the coming few slides hopefully would be like a simplified, but really it reflects many, many months of work for a lot of people. So. Just a quick review. Transplant medicine is a fairly new field, but it certainly has been, evolving greatly over the past few decades. The first solid organ transplant was attempted in 1954 and was successful because it was between two identical twins. It was a kidney transplant. And then by 1960, genetically different transplantation was ventured into with the use of irradiation of lymphoid tissue, and then subsequently the use of azathioprine and steroids that were made available at that time. Cyclosporin came about in 1980 and made heart and lung and liver transplants more successful. And then I think after that, it's it's just been a snowball of successes in immunosuppression. And because of this, thousands now of solid organ transplantations are being done yearly. People are living longer, better lives due to improved immunosuppression, but also improved surgical techniques, and also because of screening and prophylaxis of infectious diseases, and then the appropriate post-transplant follow-up. So why look for infectious diseases and prophylax them? First of all, after problems with organ function, problems with rejections, infections post-transplant probably present one of the biggest problems that can present in very complex ways because of immune suppression, but also a lot of factors play into the presentation: the patient exposure, the timing after the transplant, and the type of the transplant. So all these factors make the presentation really complex. The clinical manifestations may not be typical, and of course the severity of these infections are much more than in immune-competent patients. And as the old saying goes, prevention better than cure. But it's not really only a saying. Multiple studies, and we can provide the references for the studies at the end. But multiple studies have shown that effective screening and prophylaxis do actually improve, the survival of the organ and also of the patient. So these things really work when they are applied appropriately. So in infectious diseases, what do we screen for, and what and how do we screen for? Well, let's just a reminder of how infections happen after organ transplantation. The first 6 months probably present the time where the patient is most vulnerable to these infections, because they are at that time they're at the highest level of their immune suppression. Between the time of transplant up to 1 month, we commonly see your regular hospital-acquired infections. These are your UTIs, your catheter-related infections, vascular catheter-related infections, your surgical site infections, and pneumonias, hospital-acquired pneumonias, your usual hospital-acquired infections. From 1 month to about 6 months, you start seeing opportunistic infections showing up, and of course the biggest notorious group for that we always on the lookout are the herpes viruses. Latent viruses, they can reactivate, or the patient can get them as a primary infection, which is even a more severe disease. Opportunistic bacteria like Listeria nocardia, and of course the infamous Aspergillus and Strongyloides in the areas of parasites. After the first 6 months, patients will be coming back from the community, so you will see severe community-acquired infections, severe pneumonias, bad influenzas with complicated influenza, as well as some other opportunistic infections, namely PCP and various fungal infections. So if you look, really all categories of microorganisms are involved: viruses, bacteria, fungi, and parasites, and protocols exist in each center to look at these groups of organisms, the commonest, what we can detect and what we can do something for. So as we go in the slides, we're going to look at what viruses we screen for and how we prophylax them, what kind of bacteria, what fungi, and then there are certain things that you do for certain candidates, not for everyone. So these protocols may vary from center to center slightly, but really in essence they all revolve about the following. So first things first, before you start looking for potentially, infections due to exposures and latent infections, you want to perform a thorough history and physical, because that's what's going to tell you if the patient has an active infection right now that may make a transplantation a disaster or result in patient demise. After that, you want to identify what kind of exposures the patient had that may place them at particular risk at particular infections after immune suppression. And that's why, if the fellows know, our consultation for these transplant candidates typically are much longer. There is a lot of verbiage going, but for a reason, because you really want to identify which patients you want to screen for other things or keep an eye or prophylax more than others. And so we pay special attention to, beside the usual social history and that we've investigate, exposures to tropical diseases are very important. They show up after transplantation. Endemic mycosis, people who reside in areas that have high likelihood of getting fungal infection that may disseminate. Of course, potential exposure to TB, STDs, and risk factors for hepatitis and HIV. And also, we'd like to know what kind of infections they had in the past. For example, people going to liver transplant, if they had biliary infections, what kind of infections they had, and you need to pull all that data so as to know what to expect after. And then, of course, last but not least, their vaccination history. So that's probably the simplest intervention you can do to prevent a multitude of illnesses. So, starting with the big group, viruses, because these are actually the hugest group. This is a long list, but I promise you the rest of the microorganisms are not as many. So all candidates will get screened for harboring CMV with measuring CMV IgG. CMV not to be underestimated. It's one of the frequent problems in the first 6 months, although late CMV disease may happen, can be very devastating, resulting in even organ rejection, more impairment of the immune system, concomitant infections may happen. So bad disease if it happens. And we do have prophylaxis for it, so that's something worth looking at. Herpes simplex 1 and 2. Herpes simplex is a very prevalent type of infection. Most people by adulthood, 90%, they're probably exposed or may harbor immunoglobulin against the herpes viruses. And most solid organ transplant will get prophylaxis at least the first 3 months against herpes because it will reactivate. We measure, however, just for risk stratification, primary HSV infection can be severe, can be multi-organ, acute hepatitis, meningitis, the whole 9 yards. So we would like to know who is negative, so you kind of give that patient more attention. And if they develop signs of symptoms consistent with primary HSV, you kind of recognize it early. Reactivation of HSV is also bad, but really primary HSV infection can be devastating. Varicella zoster virus, we check for IgG. We all had patients who had disseminated varicella or shingles, or bad shingles after either disseminated chickenpox or bad zoster after transplantation. This is something we can look for, and if we were early enough, we can vaccinate patients before transplant, or we'll be on the lookout for active disease. EBV virus, we check for IgG, and again, EBV, similar to the story of HSV, most likely acyclovir would help prevent that, but people who are positive for, recipients who are positive for EBV or get organs that are positive for EBV, they are at increased risk for post-transplant lymphoproliferative disorder. So if the patient is positive, maybe that's something you want to keep a closer eye on, and if signs develop, you want to intervene and, initiate treatment early. So it just shows you your patient profile. Hepatitis A, for obvious reasons, acute hepatitis A in the non-immunized, immunosuppressed patient can be a fatal disease, can cause fulminant hepatitis. People travel, people like to eat, so IgG, and we have a very potent, highly immunogenic vaccine for it. Hepatitis C antibody, because that's something you want to investigate if the patient have an active infection, may actually contraindicate solid organ transplant non-liver, other than livers. Of course, if they have active hepatitis C destroying the liver, you need a liver, that's a different situation. But if you're giving another organ and patient has uncontrolled active hepatitis C, high mortality, and with immune suppression can just lead to fulminant hepatitis. Hepatitis B, we screen by 3 things. You look for the core antibody, which I'll talk about it. A core antibody, you look at the surface antigen and the surface antibody. And we have effective prophylaxis if the patient is going for liver or other solid organ, and this is something we can control. HIV, for obvious reasons, uncontrolled HIV will contraindicate most solid organ transplants, and this is something nowadays we can control as well with antiviruses to optimize potential solid organ transplantation. And then the measles, mumps, and rubella IgGs, especially if the patient are from certain geographic locations, you may consider vaccinating non-immune patients if we're early enough prior to transplant, because it's a live vaccine, as we will see later. Biggest group, I promise. I'm coming. So that's the biggest list, really the group of viruses. Special population can be screened for the HTLV virus 1 and 2. People, depending on the geographic location as well. Not that we have great prophylaxis or even vaccine for it, but it is associated with leukemia, spastic paraparesis, other malignancies. So if the patient is positive, you may want to counsel them so they really truly understand the risk and benefit. And also you want to follow them till that point. If it comes, you need to treat them. So again, no effective prophylaxis, but it's something that's worth noting. Moving on to bacteria, not much, right? So again, first things first, you want to know if your patient is colonized with a multidrug resistant organism, of course. That's our standard screening for MRSA, VRE, carbapenem resistant organisms, and Burkholderia cepacia, especially in cases of lung transplantation. Of course, you want to rule out latent TB. I mean, we've all seen patients after transplantation with reactivation of DV, disseminated disease, infection of the transplanted organ, whether it's a kidney or whatever. Bad disease. If you think that the patient has the right exposure, you screen, and even if the test is intermediate and there's no evidence of active disease, go ahead and treat them as latent TB. Dr. Kasanas can tell you the patients she sees. Now, our hospital chose to screen now with the EGRA, or the quantiferon, which is detecting the gamma interferon against the tuberculous bacillus. Some centers still use the PPD. We elected to use that, not because of sensitivity, it's more for specificity and just it's quick. It's a little bit more specific and it's faster. But anything that will affect the sensitivity of the PPD will affect the quantiferon. So if you're checking your patient and they're immune compromised because of chronic steroids, organ failure, you're not getting good read on your PPD, your quantiferon may be negative or intermediate, so you have to put that in the back of your mind. But that's what we use now. And of course, last but not least is your RPR. So the 2 things that you need, the bacterial pathogens, that's standard, all candidates, TB and syphilis. Make sure you look and make sure you treat as much as possible before transplant. Okay? Moving on to fungi, really screening for moles or fungi in the strict sense, meaning we actually advocate that mostly for people from endemic areas, namely the cocci and histo regions. One exception is the lung transplant candidate. They get the surveillance BAL to see what they're colonized for, and if you find the fungus, you need to acknowledge it, prophylax against it, and so all that. But we don't necessarily go look for Aspergillus in other recipients for non-lung. They're not asymptomatic. But an exception of that, of course, coccidio in people coming, transplant candidates coming from southwest United States, we screen with antibodies, coccidiomycosis antibodies, serum, ELISA, and prophylax these patients. Prophylaxis is effective. Histoplasma, serum antigen or urine antigen, again, endemic areas, as you can see here. But there has been a debate, who's you screen, and it seems that most, the recommendation is really prophylax people with history of infection, or if you detect the actual antigen rather than just, so it's a little bit narrower than cocci. Cocci, if you find the antibody, you prophylax these patients. Last group are parasites. All candidates now, our recommendation in this center to screen for strong G. Loidis stercoralis. We use the IgG in the serum. This helminths is endemic to the tropics and subtropics, and there are sporadic cases in temperate areas. But lately in the United States, we've seen more, increasing cases, and it can be devastating. I mean, one thing about this helminths is that it can complete the full life cycle and multiply in the human host, unlike, other worms where the human host is the dead end. Whatever you got infected, the number of worms, you stay with that. No, this worm can multiply, and what keep the multiplications in check is the immune system. So when patients get immunosuppressed, this goes out of control of what we call hyperinfection, when there is, multiple parasites between the intestine and lungs, or disseminated disease when they're outside these two organs, for example, CNS, and we had patients, right? So screen all candidates for this parasite, and based on the history, there are some based on the exposure, there are recommendations regarding trypanosoma cruzi, Chagas disease, and if you see with the map red in the South America and Mexico, you look for antibodies for candidates coming from that area. And for Leishmania, these are the kind of geography you're looking for: South America, Mexico. But for visceral leishmaniasis, really North Africa and Southern Europe, and part in Asia. That's really endemic. So we look for the antibodies. Now, Chagas and Leishmania, we don't necessarily have effective prophylaxis for that, but it's something to make note of and follow. And the patient need to know the risk getting immune suppression and developing these diseases, and then you look for them, you follow the patient, and intervene at the right time with treatment. Schistosoma for kidney transplant patients, these are the endemic areas, again, mostly Africa, with the Hippotomium and Mansoni, but Japonicum in far east, and also areas in South America. For schistosoma, it's worth it because we have effective treatment for it. So just bear in mind, we all see patients referred from other countries for transplants here. So I think these are the big ones to remember. So all candidates, and then exposure history for parasites. So you've done your history, you examined the patient, and you did all your screening. There are a few things that maybe will contraindicate solid organ transplant at that time. Of course, active infection, this has high mortality. Active TB, we mentioned. I believe up to now, Belcorderia cepacia, it's a multi-drug resistant organism. You simply do not have antibiotics for it. And lung transplant. If the patient is colonized with that, many centers would not transplant. I believe this center as well.
Especially what type, which type it is.
Yeah, that's right. And the lung transplant panel will actually look into active TB. It will just disseminate and the patient will die, and controlled HIV and Hep B and C, as we mentioned before, for non-liver. So you need to control these first as much as you can before. And then just a reminder, these patients may be on the transplant list for a while or for a few months. If at the time of transplant you want to repeat all the serologies, if they were longer than a month, I mean, things happen, patient may convert their PPD or become positive quantiferon, and you may want to initiate prophylaxis. Post-transplant serology, I think it's a little bit outside the scope of this, but we follow patients according to their prior serology, their donor status, what's going on. So it's a kind of different talk, but post-transplant serology will also occur in certain patients. I mean, I think the easiest example we can all remember is the patient, the recipient who gets an organ from someone maybe who had a high-risk status. Someone who was maybe an IV drug user but was negative HIV, Hep C, and all that was negative. The recipients are people who want to you follow closely, more frequent checking them for B and C and HIV. Prophylaxis. So we've done our exam, active infections. We know what the patient profile looks like from the serology, what they're at risk for. The rationale. So I guess this is a repetition, but again, all these asymptomatic infections that you really don't see before can turn into overwhelming sepsis very quickly. So that's the rationale, and actually will fail the transplant. Patient will have organ rejection in some cases, high morbidity and mortality, and also will limit your treatment options because of the type of medications they're getting. A lot of interactions, so you'll find your options getting smaller because of the other medications you have to account for and their interactions. And again, multiple studies have shown that effective prophylaxis does work in case of patient survival and organ survival. That being said, again, first things at first, the best prevention you can do is the vaccination. So when you see these patients before getting the transplantation, you want to make sure you get their vaccination history and complete the vaccination series as much as possible early, because as the organ failure continue and the patient gets sicker and sicker, they may not really mount immune response to your vaccines. So the idea is that as much as possible, the first day you see them, you're looking and you're giving them their vaccines that needed. And for some reason, if they didn't get it or they did not finish their series, they received their organ transplantation, it is recommended that you probably wait 6 months when the immune suppression is maybe less severe to reinitiate the vaccine or complete your vaccination. These are just some general rules. And then live vaccines, if you decide to give your transplant candidate live vaccine, make sure the transplant is not imminent. If it's clear that the patient has time, and make everybody aware that we're going to need maybe a month before immune suppression, and if that's acceptable, you go ahead. But if your patient is status 1 and they're going for liver transplant, do not give a live vaccine. Trouble will occur. So, and then after solid organ transplantation, usually most live attenuated vaccines are contraindicated. So you have to go case by case, but these are just some general rules. So the vaccines we use, the first category will be the inactivated. Of course, the most famous is the influenza vaccine. You need to give the inactivated intramuscular form rather than the live intranasal, and it is recommended to be given yearly. The pneumonia vaccine, there has been an update in the past year. So now for immune compromised patients, you want to use the 13 conjugate vaccine, valent conjugate vaccine, which is the Prevnar. This is like protein-based, so it's highly immunogenic. And then 8 weeks later, you want to give a boost with the polysaccharide vaccine. It's a polysaccharide vaccine, which is the Pneumovax, and then a boost in 5 years. So one thing to remember is always these pneumonia vaccines, how many, how often. It's up to age 65. So usually the Prevnar, the protein conjugate, is given once, and then the Pneumovax up to 3 years till up to 3 times, up to age 65. It has to be 5 years intervals. So the longest you're giving is 1 Prevnar and 3 Pneumovaxes. After that, is not found to be efficacious. The pneumonia vaccine this way, and and there is a recommendation. What if the patient just had the Pneumovax, and we kind of have a small table I can share with you. Well, if he just had the Pneumovax, what do I do with the Prevnar? And there is all steps you can do to make sure they got the best pneumonia vaccine. The tetanus, diphtheria, cellular pertussis are now recommended for all transplant candidates, and it's given once. So it's good. We give them once, and regardless of their, if they didn't have the Tdap before, of course, or if the vaccine status is unknown. If you really don't know, nobody knows, go ahead and give them the vaccine. Also, regardless on when was the tetanus boost was given. So that's fine. I'll tell you, I think I got the TD a couple of years ago. Well, this vaccine is very important. Pertussis is causing a lot of problems. We're going to give you this once. Okay? Again, hepatitis A vaccine, very immunogenic, are given to patients who are non-immune, negative IgA, given 2 doses, 0 and 6 months. Hepatitis B vaccine, the recommendation for immunocompromised or transplant candidates is using the Recombivax HB, which is just a higher dose from the standard Twinrex. So it's a 40 microgram per mil, and we have evidence that when you give it in accelerated fashion, like day 0, 7, 21, fast, and then a boost at 12 months, it's pretty immunogenic, so patient, compared to the traditional longer series, because it's a very important vaccine that the patient get. And then in about month and a half or 2 months, you want to check their antibody, just like what we do to our HIV patients, and you want to make sure they have a robust immune response, at least 10 microgram per deciliter. If they did not mount an immune response, you can go ahead and repeat the series. But if you repeat it and there is no response anymore, vaccination is just futile, so we don't. But one important question to answer: if they're not responding, make sure you evaluate them for active chronic hepatitis B that you're not detecting. Maybe do the hepatitis B DNA PCR, see if you detect any maybe chronic infection. But some people just don't respond. Just a reminder, I know we all use the Twinrex because it's easy. It has the hepatitis A and B together, but it's not immunogenic in these populations, just like our HIV population. It has low immunogenicity, so you do have to give them 2 separate vaccines, A and B, separately. And then the latest recommendation is the human papilloma vaccine, which I think is like a breakthrough vaccine, right? So again, there is no, of course, studies post-transplantation in the immune compromised. So if possible, you want to give the series before transplant. And the recommended formulation is the quadrivalent. There is 3 different ones, but quadrivalent vaccine, the Gardasil, it has the 4 serotypes that are carcinogenic, and that's the one recommended. The CDC recommends females age 9 to 45, men or males 9 to 26, but there is a debate. Well, if the patient is 28 and didn't have significant sexual exposure, would you hold the vaccine? So some people are recommending, patient by patient, you may still give it outside. And I don't know if you've seen patients who are immunosuppressed, whether at Moffitt or here, with severe HPV disease. I mean, if that's something we can prevent, I think we should get every opportunity.
When did they change the age for female? I thought always it was 9 to 26. I didn't know.
No, this is subsequent studies, and there is still a lot we need to know about the HPV. I mean, now it's 3 doses, 0, 2, and 6 months, but I'm pretty sure you're aware of the new studies showing, well, patients who received 1 dose and lost to follow-up developed an immune response. Do we really need the 3? So I think it's a work in progress. But yes, they increased the age of female to males are still 26. But again, if your patient you think is going to benefit, why not? Now, the other group of vaccines are the live attenuated, and these are the 3 categories. You have the varicella. If the patient never had the chickenpox vaccine, never had the chickenpox disease, and they IgG negative, you can give them the Varivax. Just make sure we're away from transplantation. Patient stable is not going to get transplanted soon, and the transplant team know that his zoster vaccine follows the general recommendation, general population, age 50 and above. I just want to make you aware, regardless if they reported an episode of zoster, because we've seen people who say, well, no, I didn't get it because last year I had zoster, I'm immune. Really, recommendations are you go ahead and vaccinate these people as well. And again, the MMR if they're non-immune from certain geographic locations. There is a lot in the CDC website for adult immunization in immune-compromised. All right, so progressing now forward to what kind of prophylaxis we need to use. I will start by peri-operative antimicrobials, and I'm talking about this slide in front of the person who wrote the recommendation, so correct me if I'm wrong, Dr. Montero. So you need to take into account few things. Multidrug resistance, colonization, you want to get that into account to design your peri-operative antibiotics, but the following are pretty standard. I'm pretty sure you can use them in most of your patients. For heart, the recommendation is Vanc and Cefepime, 24 hours if there is no issues with active infection or prior or anything you're really treating. I'm talking strictly prophylaxis. Patients is fine, it's clean. The addition of Vanc was supported by the fact that these patients are in and out of hospital, and we had a lot of trouble with surgical site infections with MRSA. So VANC is effective, is needed, and of course cefepime. For lung, Clinda and cefepime, lung is a little bit longer because, again, remember, lung is the only transplanted organ with direct communication to the environment. So the lung transplant team does the surveillance BL, so they see what's going on in the recipient airway before they get it, what's going on in the donor, and then by day 5, you will get your cultures back. So you know if you need to continue the course for a treatment, what the patient had, what the donor had, so you don't end up with a horrible pneumonia in the transplanted lung. By day 5, cultures are all clean. There is nothing that you're worried about. You can stop them at that time. And then lung will get the anti-mold for Aspergillus. Again, the duration will depend on what is found in the surveillance BL. And we'll get into Aspergillus prophylaxis. Liver, peptazo, zosyn. Most people will also add micafungin, but it's really antifungal if it's a prolonged surgery or patient has other complications, biliary issues before, patient renal failure, because liver and pancreas, that's where candidemia becomes a problem, intra-abdominal. So if everything is clean, you're not worried, 24 hours, zosyn, micafungin, but you have to review the patient's prior history, infections, what happened in the past. You may need to go longer if there are issues prior to transplant. And if they had biliary drain or whatever, what colonization did they had in the biliary tract. And then kidney is probably the least prone to these kind of hospital-acquired infections. So our standard cefazolin for 24 hours if there are no concerns. So again, the most busy is the viruses section. It's not going to be like that for bacteria. Remember, for the viruses, the big one to remember is the CMV. I think Dr. Montero gave a talk before. CMV, there are two approaches how we prophylax CMV. There is universal prophylaxis for anybody who's CMV positive, or get negative but get a donor who's positive. And there is the preemptive, where you just follow them, no prophylaxis, but you follow them weekly, you follow the CMV reactivation and see if they develop a viremia, and then you treat. What we do in this center, based on judgment of best evidence, is the following. If the status of donor recipient is that the donor is positive and the recipient is negative, that's your highest risk factor to patient to develop severe CMV disease, disaster, organ rejection. So I can tell you, for this first category, everybody is going to get prophylaxis at least 6 months, longer in certain situations like lungs. Everybody get valganciclovir for 6 months. The caveat is that heart and lung will get the immunoglobulin, will get the cytogam, okay? And then in a certain protocol till week 12. And then lung, we go longer, 12 months. In other centers, they do lifelong, but this is what we felt is most appropriate. So easy to remember. Donor positive, recipient negative, everybody is getting something. Heart and lung are getting 2 things, okay? Donor positive, recipient positive. Most solid organs we do, kidney, liver, lung, and pancreas, will get oral ganciclovir. No need here for cytogam. At least 3 months, longer for lung. But heart, we do recommend preemptive, weekly follow-up, and with the earliest indication that the patient is developing CMV viremia, you treat. Now, people went back and forth a lot regarding which is better. Meta-analyses have suggested that this approach, where you're offering more universal prophylaxis, had a little bit of advantage in survival, organ survival, and so forth. The other argument was that, well, you decrease resistance and cost by doing the preemptive. Didn't pan out. The lab cost was huge, and also resistance was very comparable. So for that reason, we felt that for our center, that is most reasonable and safest for the patients. Now, when the donor and recipients are both negative, these are, that's the least risk. So generally speaking, in most solid organs, kidney, heart, lung, and pancreas, there is no prophylaxis. You just follow them closely. But liver, acute CMV, you can lose the liver, acute hepatitis. So the recommendation is that you do use ganciclovir for 3 months. Now, whoever is not getting CMV prophylaxis, you're using acyclovir for HSV prophylaxis, regardless of their serology, for reasons we discussed before. the recommendation is about 3 months for HSV. Busy slide, but if you look at it again, you will remember.
So, you look for card only based on what? Since you just said the evidence is.
Yeah, when people looked organ by organ, they kind of had more studies which organs did better, and I think most of the studies pointed out if donor negative had CMV, both preemptive and universal prophylaxis had similar outcomes, unlike when donor positive, recipient negative. It didn't pan out. People who did get the prophylaxis did better. It's just based on studies, not, not.
I think previously donor positive, recipient positive for the heart transplant, they classify like the patient who got anti-immunoglobulin versus the patient who did not.
Now, this is a good point. Anytime your patient gets an anti-rejection, anti-lymphocyte medications, heavy-duty medications, a lot of centers, including ours, will use all prophylaxis. So if the patient is using anti-lymphocyte, go to the highest category, prophylax them, because, and this is even true, even say if you finish the prophylaxis 3 months, 6 months, whatever, and patient came back later date, then you will reinitiate all your prophylaxis because of the high risk. Okay. All right. Now, hepatitis B and C is another area, which again, kind of busy, but just something about hepatitis B. People who have chronic active hepatitis B infection resulting in liver failure requiring liver transplant, or they had a prior hepatitis B infection and they need a liver transplant now for other reasons. The way we divide these patients is by looking at the surface antibody. I think that's the most important, the kind of concept that you want to have. If your patient has a surface antibody, they are kind of in a good situation to get their liver for their liver failure or to get other solid organ transplant without the use of prophylaxis, because they have the antibody. That's the whole point. If they don't have the antibody, then you look at the antigen. If they have active antigenemia and they are getting a liver, then you need to use 2 prophylaxis. You want to give them the oral antiviral, but that's also where we use the HBIC, or the hepatitis B immunoglobulin. So if you want to remember it, the antibody is for the antigen. And then you also use the oral. If the patient has chronic hepatitis B with evidence of core antibody, but they don't have antigen or antibody, then you can only use only the oral antiviral. You don't have to use the HBIC. Liver. Now, if they are getting another organ, you don't have to use the HBIC for antigen positive, although you would want to control their disease very well. They're getting another organ, then you make sure you control their disease and put them on oral. Another busy slide, but I'll send it to you. Look at it a couple of times. Hepatitis C, we don't have now. It may change in the near future. Great prophylaxis for it. If the patient gets a liver for hepatitis C infection, what we do is we follow these people closely with PCR, with liver functions, with liver biopsies, to see if the hepatitis C reinfect the new liver and then indicate treatment. So that's the problem with hepatitis C. But there are so many new, safer medications coming out. By next year, we may have a prophylaxis protocol for hepatitis C. But now it's just follow-up. Now, from here, it gets easier. The viruses are usually the bigger problem. A lot of details and a lot of variation, too. So for bacteria and PCP, most solid organs will get the Bactrim for 6 months, except lung and small bowel. They have very high incidence of bacteria infection, PCP, and they continue lifelong. We don't have a lot of experience with small bowel here, but with lung, we do, and they continue lifelong for lung transplants. The best option is really Bactrim, but alternatives can be Dapsone and etovaquinone. For Candida, the liver usually is the one that you need to prophylax, post-operatively. For heart, if there is no evidence of active candidemia, Miselex is enough. For lungs, you cover Aspergillus, not Candida, right? So you're using voriconazole, Advil-C. And for need, it's not needed for kidney, unless you have evidence of Candida. But for Candida, it's really mostly the liver. And then remember, lungs, you don't cover Candida, you cover molds. Aspergillus for lungs, it's voriconazole, first 4 months. After that, again, with lung, you're always going to go back and see. It depends on the BL surveillance, really. You're going to continue, you're going to change, what are you going to do? For heart, if they have documented prior colonization or had a prior infection, then they go on prophylaxis. If liver, if they same thing for liver and kidney, they have to have some kind of history for you to use an anti-mold. Just a reminder that prolonged voriconazole in lung transplant patients have been strongly associated with skin cancer and periosteosis, so it's not a medication that's without side effects. Parasites, toxo, again, for recipients who are positive or get from a donor positive, using Bactrim for 6 months for all organs will take care of that. The problem is with heart. Heart patients, if they are positive, the recipient positive, or if they get a donor who's positive, then they stay lifelong on Bactrim for toxoprophylaxis, because it can reactivate, it goes right in the heart and will cost you the organ. Strongy, you have to treat everybody whose serology is positive for reasons we discussed earlier. The drug of choice is ivermectin, 2 days, and then you repeat in 2 weeks. Alternatives are albendazole.
You repeat the serology, or you
No, you repeat the treatment. Yeah. So 2 microgram per kilogram per day for 2 days, and then in 2 weeks you repeat the same dose. Now, all transplant candidates and recipients, of course, will get a lot of literatures about safe living, post-liver transplant, post-organ transplant. I mean, you can't do all these prophylaxis and serology without really talking about the basics, the bulk of what they do that will prevent problems. I mean, you stress hand washing and explain reasons for that, what they eat, what they drink, food safety. They're provided by a website that can guide them and frequently ask questions. How do I cook this? Can I eat this raw? What do I wash my vegetables with? All that kind of just simple daily living things. We also encourage them to avoid crowded areas in respiratory season so they don't come down with influenza. Safe sex practices, pet health, see the vet. There are certain pets you want to be careful with, like birds and parrots. Don't, especially that first 6 months, don't clean, where the pet feces and all that. We talk about their careers, what they do. Do they work in hospitals, in jail? What do they do in labs, and then, of course, travel. We encourage all these patients, if they're going to travel outside the country, to seek advice regarding to travel specifically. Again, you repeat all the simple infection prevention measures, hand washing, the cooking and drinking bottled beverages, using of nets in mosquito prevalent areas, and then you update the vaccination as appropriate. Anti-malaria prophylaxis, we can't stress the importance of that. Malaria will kill the immune suppressed patient. And then travelers' diarrhea, give them advice. And also we provide them with medications like Cipro and Azithro for self-treatment. You give them guidelines, what they watch for. And then experts recommend have an exit plan if you get sick somewhere that so we encourage these patients, if something happened, to have like travel insurance in place that they can come back quickly. And I think that's the end of it. And with that, I thank you. Any questions?